So good afternoon, everyone. Thank you for joining this webinar. I'm Grace Arenas from Medical Affairs, and it is my pleasure to introduce our two wonderful speakers for this webinar. So our first speaker, it is Leah Wright. She's a trustee of CMV Action, a registered UK charity, and she would walk us through the patient and family experience of congenital CMV infection. So Leah, the microphone is yours. Thank you so much.
Thank you. Hi everyone, my name's Leah. I'm a mum of two, and as Grace mentioned, a trustee of CMV Action. My eldest was born with congenital CMV, which I had never heard of. I'm going to talk to you now about our story and also what we do as a charity in respect of CMV. So, warning signs. On the Thursday before Beth was born, we had a growth scan. I assumed the baby would be late as she was measuring small, but went into spontaneous labour just a few days later on the Sunday, and Beth arrived very swiftly thereafter. She was small for dates, and she had the classic purple pinprick rash, both of which can be signs of CMV, but were dismissed by a paediatrician that examined her as being down to her fast arrival. The next day, she failed her newborn hearing test. Her hearing ear passed quickly, but her non-hearing ear failed. It's a further sign of CMV, but again, it was put down to her speedy arrival and that perhaps the mucus hadn't cleared from her ears. Our journey, the next steps. The hearing test was repeated at 2 weeks old. Again, her right ear passed quickly, but her left ear failed. At that point, we were referred to the Children's Hospital, where at about 5 weeks of age, Beth had comprehensive hearing testing, which confirmed she was severe to profound hearing loss in her left ear. The hospital were amazing. They got me in with a consultant there and then who did mention CMV, but thought it was probably unlikely. And we were advised not to Google it because it can be quite scary. We did Google it, but quickly stopped, having realised that the advice was good. We were referred for further testing, which was a urine test and MRI, which was quite distressing as a parent of a tiny baby to see them being put through these things, which led to that approximately 12 weeks of age, Beth was confirmed with a congenital CMV diagnosis, which meant we were too late to try antivirals because they have to be administered within the first 28 days from birth. I'm just very going to quickly say about what CMV is, because obviously Lisa will cover that later. It's a really common virus which can infect people of all ages. It can pose a serious impact to unborn babies if contracted by a woman during pregnancy. And congenital CMV is one of the most common non-genetic causes of inner ear hearing loss and a major cause of childhood disability. What did a diagnosis mean for us? Post-diagnosis was incredibly stressful and anxious, and it was a horrible time. I became completely convinced at one point that Beth was going to lose her sight, which was really distressing. We were worried that she wouldn't meet milestones, and looking back now, I feel like we were robbed of the innocence of being first-time parents. We question why us, what have we done? I think we try and rationalise these things, even in strange ways. But now I feel incredibly lucky, which strangely comes with its own sense of guilt, because Beth is the tip of the iceberg with a congenital CMV diagnosis, and many, many children are much more severely impacted. I became really passionate about educating anyone and everyone that would listen about CMV, even though I've still got a lot to learn 6.5 years later. Where are we now? Beth is nothing short of amazing. We're starting to see her become more aware of her hearing loss in social settings. She will turn her hearing ear to you now. Her hearing loss doesn't stop her from doing anything, despite the fact that she is currently unaided. We are concerned that her hearing loss is impacting her learning, but it's almost impossible to measure whether it's that or ability or anything else. And she is considering whether or not she would like to try hearing aids. What have I learned as a parent of a child with CMV? I think you will love your child fiercely no matter what the complications are that may or may not arise, because to you they are absolutely perfectly them. The world in some ways is kinder than when I was a child. I think people are much more accepting of disability now and understanding that there's a long way to go. And as everyone says, children are remarkably resilient. As I say, nothing stops Beth. How does Beth feel about her diagnosis? Well, she's still only 6.5, so I guess how she feels may change as time goes on, and that she'll go through different stages with how she feels about it. But at the moment, she's pretty positive. She has been known to refer to her hearing loss as her superpower, and even to wish she was deaf in both ears when her little sister is being noisy at bedtime. She craves less sound rather than more. When I explained that hearing aids will give her the ability to hear more rather than less, she decided she wasn't sure whether or not she did want to give them a go after all. This is the CMV Action team. Who are CMV Action? Well, we're the only charity in the UK for those affected by congenital CMV. Our vision is a world where congenital CMV no longer poses a risk for babies and children. Our mission is to protect babies and empower families. We have a number of objectives. Supporting families affected by CMV. How do we do this? We do this through supporting those diagnosed in pregnancy or with a child that's received a diagnosis. Educating professionals, parents-to-be, and the general public about prevention of CMV. We do this through literature, campaigns, conferences, and attending midwifery schools to do talks and providing them with presentations and such. Supporting research into testing, treatment, and management of CMV. We do this through supporting research applications, campaigning for better and more consistent management, such as pathways, and raising awareness for the need of a vaccine. We do that through targeted communication work. The work of CMV Action, raising awareness is obviously of critical importance to us. We do that through attending conferences and responding to requests for talks, presentations, and webinars such as this. We have an active website and social media channels. We provide comprehensive information free of charge to professionals and families. We work with medical professionals on initiatives such as delivering 9,000 leaflets in newborn packs soon to be given out by one particular NHS trust, and producing educational materials such as short films, which we'll be launching in June. We're members of parliamentary groups such as the National Screening Committee, who recently conducted a consultation into newborn screening for CMV. Who do we support? We support people considering getting pregnant, those diagnosed in pregnancy, pregnant professionals such as nursery workers who are at a greater risk of getting CMV, parents with a child who has been diagnosed, and we also support families who have received a late diagnosis. How does our support work? Well, we've got a Facebook group with approximately 600 members, and last year we launched our National Lottery funded initiative, CMV Connect, which has connected 75 families through peer-to-peer WhatsApp support groups, and we've received really great feedback on that. It's going really well. We also engage our medical experts where necessary in offering support and advice. How do those we support feel? The feelings around a diagnosis can be really complicated. Things such as guilt. You can feel really guilty having passed this infection onto your baby. Isolated or alone. I'm yet to meet another parent outside of my work with CMV Action that has any experience of CMV or has even heard of it. Anger. You definitely feel angry, particularly, like I mentioned, where you feel that your options have been taken away from you through late diagnosis. Uncertain about the future, what the future holds, as symptoms can evolve with time. Uncertainty can lead to fear about what might lie ahead. Shock. This is a really big one. You don't picture giving birth to a poorly baby having had a straightforward pregnancy and birth. Let down. I personally felt really let down by the system. There were things that I think should have led to me being screened during pregnancy, at birth when Beth showed signs, or when she failed her newborn hearing test. I felt let down by the obstetricians consulted during my pregnancy, and especially the paediatrician that examined Beth shortly after birth. Had she been tested for CMV at that point, or even after she failed her hearing test, we would have had the option for antivirals potentially, and to feel that those options were taken away is really hard to deal with. Alone, as I mentioned earlier, other than my relatively recent work with CMV Action, I don't know anybody that has come across CMV. Worried. The impacts can be really huge, not just for your baby and family life, but some parents have to give up work to care for their children due to the impacts of CMV, which can lead to financial worries and so on. Blame. It's really hard to blame yourself, particularly as the mother, given that you have contracted this and it's passed on to your baby. Worries about how the rest of the family will be impacted, particularly in the case where there's older siblings, or if you have subsequent children with a child with complex needs. Some people are traumatized. And grief. I think there's certainly a period of grieving for the life you thought you were going to have with your baby. How do those we support feel about awareness? More education is needed. It's imperative that relative healthcare professionals know about CMV. We need to raise awareness in the general population to help people avoid becoming infected during pregnancy with advice such as kissing on the head, not sharing utensils and drinks, and good hand hygiene. And just 6% of respondents to our survey were given any information about virus protection during their pregnancy. Why is diagnosis important? It's important to get your child the help and support they need. Of 108 respondents to a CMV Action survey, 97 were tested for congenital CMV following a hearing loss diagnosis. Those diagnosed with congenital CMV said they saw a change in medical appointments post-diagnosis with increased audiology appointments, for example. Pre-diagnosis, respondents said they blamed themselves and that they needed to know what the cause of the hearing loss was for their own sanity. Another respondent said their child had been subjected to numerous medical procedures and that these finished with the diagnosis, which was upsetting for them as the answer had been there all along. What is the impact on families? Costs. These can vary hugely from mobility devices to therapies. Day-to-day life can look very different when you have a family member with a disability, and the impact on siblings can be big. As we've mentioned, the future can already look very and feel very uncertain. And later issues. The impacts of congenital CMV can evolve. For example, hearing loss could deteriorate. We were told that this could be the case up until the age of around 6. And my experience is that the stress and anxiety has diminished the closer we've got to that magic number, but I don't think it will ever go away. Counting the costs of CMV. CMV Action commissioned a report into the costs of congenital CMV in the UK. The model calculated the cost of the NHS and government, and indirect wider population and personal cost to families. The research estimated the total cost of congenital CMV in 2016 was £729 million, a huge amount. %40 of these costs were direct and incurred by the government for health, social and educational services. 60% of the costs were indirect, such as the cost of lost productivity to society as well as the personal costs paid by families. Long-term impairments made up for the bulk of the cost burden. What can you do? You can advocate for screening. You can raise awareness and educate others. You can publish articles in professional magazines and on websites. You can complete consultation responses, such as the one I mentioned earlier from the National Screening Committee. You can sign up for our newsletter. You can signpost people who may need our support to the charity. You can follow us on social media and interact with our posts. You can fundraise, volunteer, and check our website for more information. When something like this happens to your family, I think it gives you a real passion for shouting about it from the rooftops. Thank you very much for giving me that opportunity today by listening to our story. If you would like any more information, please visit our website.
Thank you so much, Leah. Thank you for sharing Beth's story and for the incredible work that you do with CMV Action. Thank you so much. Now we're moving on to our second section to deep dive a little bit on the clinical insights of CMV infection. So this will be delivered by Dr. Lisa Berry, and she's with us. Thank you so much, Dr. Lisa Berry. I'm going to start sharing my screen with your slides. Wonderful. So Dr. Lisa Berry, a quick introduction. She is a consultant in clinical scientists. She's a consultant clinical scientist in virology, and she works at the University Hospital Coventry and Warwickshire NHS Trust. So thank you so much for joining us, Dr. Lisa. I will move the screen. Wonderful.
Thank you, Grace. Thank you so much for the invitation for today, and thank you, Leah, for sharing your story. I'm sure there's going to be a lot of questions at the end. I've certainly learned a lot from the patient experience, from listening to your family's experience, so thank you very much. First of all, I just need to disclose that I am being, our department is being paid for my time today. And this has been sponsored by bioMérieux. So just to touch on some of the more clinical sort of aspects of what Leah's already discussed from a personal point of view, and touching on CMV. It is one of the most common viral infections to impact the fetus. So it is quite surprising when you hear data that patients and pregnant people don't know about CMV and that the information is not being widely shared. It does affect 1 in 200 live births. And we've learned a lot over the last few years around CMV and CMV transmission to the fetus. And the risk is known to now be the highest within that first trimester, with a risk of transmission to the baby of 35% in that first trimester. That risk of transmission to the baby does increase as the pregnancy develops, because the blood is circulating more, the placenta is more developed, so there's more chance of viruses to cross the placenta. However, later in the pregnancy, although that risk of transmission to the baby is higher, the risk of sequelae are much more reduced because of those developmental stages that the baby has already been through. So if we then look at the risk of sequelae, it's around 23% in the first trimester, reducing right down to 0.1% in the second, and almost zero and negligible in the third trimester. This is primarily within primary infections, which hold the biggest risk. So that's of pregnant people that are non-immune and susceptible to CMV prior to becoming pregnant. And in the UK, we think there's around 20 to 40% of pregnant people that are susceptible to CMV. And of those susceptible individuals, 1 to 4% will acquire CMV during that pregnancy. And of that 1 to 4%, 50% of the fetuses will become infected, and 33% of those infected infants will have symptoms. So these aren't insignificant numbers. Next slide, please. So if we're then looking at the infection to the fetus, we can then look at those symptom rates. So it's around about, again, if it's the first trimester that's the highest, and that's what this data is reflecting. So how do we go about diagnosing CMV in pregnancy? So what we should be looking at is initially maternal serology, so checking the serostatus of the mother, looking for IgG and IgM, and looking potentially going back to the booking blood to look for seroconversion in pregnancy. Testing should be offered at the moment in a number of settings. So if a person who's carrying a baby has an influenza-like illness during pregnancy, they should be offered a CMV test. If they have symptoms of glandular fever, if they have a hepatitis, or if they have ultrasound findings of the baby that are consistent with CMV, so small foedates, fluorescent bowel, and various other microcephaly and various other abnormalities on scan. If we have a seroconversion in pregnancy, we should then be doing CMV PCR on the amniotic fluid if we've identified a seroconversion has occurred. This shouldn't happen before 17 weeks of gestation. The reason for that is because the fetus needs to be developed enough to be creating urine within their kidneys, and to then have a high enough viral load within the amniotic fluid from the baby's urine to be able to detect the virus. We also need to allow enough time for the virus to pass from the mother to the baby for the infection to happen. And if we do it too early, then a negative result isn't helpful, although a positive result obviously confirms the diagnosis. We should also be offering urine and saliva PCR testing for neonates that have failed their newborn hearing test, and also to neonates that have signs and symptoms that are consistent with CMV. So typically microcephaly, any neurological complications, or babies that have bilateral growth retardation. And we should also be offering urine and saliva PCR to any neonates that have suspected or confirmed maternal CMV infection. Next slide, please. So if we're looking at the neonatal signs and symptoms, we've already told, Leah's already mentioned about the rash. That is quite a hint that it's not necessarily specific for CMV, but it's certainly showing that something is going on with the neonate, and infection screening should be carried out, and one of those infection parameters should be cytomegalovirus. Babies should be tested if they have microcephaly, ventriculomegaly, calcifications, and various other neurological complications. Also, if they have bilateral intrauterine growth retardation, and also if they have hearing loss. And it's also one of the tests that should be carried out for hepatomegaly and splenomegaly. Next slide, please. So there have been some huge advances around management of cytomegalovirus in neonates and in pregnancy. So during pregnancy, we can now offer high-dose acyclovir. That's 8 grams daily for the mother to prevent the virus crossing the placenta and impacting the neonate, and that's been shown to be highly successful in reducing complications to the neonate. If, however, the baby does become infected with CMV, the neonate can be offered antiviral treatment, and that's valganciclovir or ganciclovir for at least a minimum of 6 weeks, potentially up to 6 months, dependent on how the baby copes with the antivirals, and also how progression of the illness carries on. But we do need to monitor the baby, because there are side effects associated with ganciclovir use, predominantly thrombocytopenia and particularly neutropenia. And all infants who have a confirmed CMV infection should be given extended follow-up for hearing and neurodevelopmental follow-up to offer support that's needed. Next slide, please. So if we touch on human CMV, what is it? So it is a beta herpes virus. And that picture in the right-hand corner is the typical owl inclusion bodies that we can see on histopathology. It is highly prevalent. And it has a 60% seroprevalence in developed countries and over 90% in many developing in countries. It's associated with socioeconomic conditions, with those with lower socioeconomic conditions having a higher prevalence. It's not the most contagious of viruses. It has an R number of 1.7 to 2.4. So that means for every individual who's infected with CMV, around 1.5 to 2 people will become infected. I think we all became familiar with R numbers during COVID presentations. So hopefully that number will be familiar with you. The transmission is via saliva, urine, breast milk, genital secretions, and blood and organs. So with the saliva and urine, that's why, as Leah said, nursery workers, for example, are at higher risk of acquiring CMV. And why you can do some just good hand hygiene and practices and advice to women who are having babies that are CMV negative as to how they can protect themselves from transmission. So CMV is a significant pathogen. As I say, it's highly prevalent within the population. Oh, sorry, next slide, please, Grace. It is highly prevalent within the population. However, there are specific clinical scenarios where CMV is a particular problem. We've discussed one, and Leah's presented how CMV impacted her family. But in other areas where it can cause issues is within immunosuppression. It can influence disease outcomes and require targeted management. And we need to have early detection through diagnostic testing so that we can manage the CMV and we can tailor those treatments depending on the clinical setting. Next slide, please. So in terms of CMV pathogenicity, CMV generally enters the body through the mucosal and glandular epithelial cells, which is why it's so transmissible through saliva and urine. It does have a very broad tropism for infecting many cell lines, such as connective tissue, vascular endothelial cells, hepatocytes, and particularly alveolar epithelial cells and neuronal cells. And that explains some of the clinical syndromes and symptoms we see, with pneumonitis being one of the prevalent presentations of CMV in immunosuppressed. And with the neuronal cells, why we can sometimes have encephalitis presentations for cytomegalovirus. The cells are lytically infected during the acute phase, and essentially they then become latent in monocytes in the blood after they've infected and spread around the human body. Next slide, please. So once you've had a CMV infection, essentially you are infected for life, for want of a better word. And the virus and the host immune system act in coordination with each other to keep the CMV under control. And there's very complex host virus interactions. Essentially, what then can happen is during inflammation, that can be a key driver of reactivation. And this latency and reactivation keeps happening, but generally speaking, that is then controlled by the immune system. However, then in the setting of immunosuppression or immunosuppressing states, that immune control can be lost and the virus essentially wins the battle with the host. And then that means that the virus can then start replicating and causing disease. This can be altered by prophylaxis and preemptive treatment. And also in the context of some immunosuppressing states, reducing that immunosuppression so that the host immune system can then regain control. Next slide, please. So I've touched on this a little bit. There are many manifestations of cytomegalovirus. In the immunocompetent individuals, this predominantly presents as it can either present asymptomatically, or it can present as an infectious mononucleosis type presentation. So that's your glandular fever, so your influenza-like illness, feeling very run down, feeling very tired, just generally feeling viral. We also have hepatitis. That's quite a common presentation. Again, that can happen within the immunocompetent. And when we're getting then into these other organ systems, that's more when we're looking at the immunosuppressed individuals. So pneumonitis, we get certainly in transplant settings, we often get patients presenting with pneumonitis. We get retinitis. We used to see an awful lot of CMV retinitis pre-HIV antiretroviral treatment coming in. Colitis, we've touched on congenital CMV, and we can also have an encephalitis and a meningitis where CMV attacks the neurons. Next slide, please. So if we just touch on the encephalitis, encephalitis is a clinical syndrome, which is it's just inflammation of the brain and inflammation of the brain parenchyma. This can either be driven by an autoimmune conditions. We can have post-infectious encephalitis type syndrome in the pictures of ADEM. We can have paraneoplastic, we can have idiopathic, and there is then obviously the cohort of infectious encephalitis. Next slide, please. So if we're looking at specifically encephalitis and viral encephalitis, the incidence varies, but in Western settings, it's about 0.7 to 12.6 per 100,000 adults, and higher in children with 10.5 to 13.8 per 100,000 individuals. The higher rate in children is probably reflective of the fact that they are more likely to have a primary viral infection earlier on in their age cohort. And if we're looking at the most common presenting virus for encephalitis, which is HSV, it has a bimodal distribution, so very, very young and the very, very old. And VZV and enterovirus are also common pathogens of encephalitis. When we're looking at CMV, it is a significant pathogen. It is rare, but it is significant, and this is predominantly seen in the immunocompromised patients. So when we're testing immunocompromised patients, we're presenting with an encephalitis or an encephalopathy, we should be thinking about testing for CMV. And we also must remember as well, there are a number of travel-related encephalitides, such as West Nile virus, but that's epidemiologically linked to any travel-related activities. Next slide, please. So if we're looking at the clinical presentation of a clinical encephalitis and a viral encephalitis, to be suspicious, we need to have the major criterion and the minor criterion. So we need to have an altered mental state, lethargy, personality changes, status epilepticus, for example, and also a documented fever or new focal neurological signs, or a CSF white cell count and abnormality on brain imaging. That's not, we don't need to have all of these, but we do need to have a number of them to be hitting those criteria. Next slide, please. And if we look at the causes of viral encephalitis and some of the risk factors, this is from the Solomon paper. As you can see, there's a number of different viruses that can cause an encephalitis, and in those herpes virus families, there is CMV that is there, and this can also cause a retinitis and a radiculitis as well. Next slide, please. So sorry, if this doesn't project very well, this is taken from the Solomon guidelines, and this is sort of our key document that we utilise in virology for looking at the management of encephalitis individuals. So we need to have the clinical features, we have the LP, and we have imaging. And if we're suspicious, all patients should be started on acyclovir. That's because that covers the majority of the viruses that are treatable that can be causing an encephalitis. Obviously, if we get another pathogen, we may need to switch that treatment, or there may not be treatment available dependent on what the etiology is. But we should be testing at the very minimum for herpes varicella, enterovirus and parechovirus. And then if we're looking at more immunosuppressed populations, we should be extending that panel out to include things like CMV, EBV, adenovirus, JC virus, etc., dependent on what else is going on with the patient. Next slide, please. Sometimes it isn't always easy to link the pathogen with the cause. However, there is a hierarchy of criteria that mean that organism that's found in that particular organ site is causative of the infection. And if we're looking at the brain, if we find the organism within the brain, in the CNS, so for us it would be a lumbar puncture and CSF, then we can think that that is what's causing it, and then we need to target our treatment accordingly. Next slide, please. So this is looking at the outcomes of CMV in patients that have had a CMV confirmed encephalitis compared to other viruses that are found in the CSF. And as you can see, there's a link with particularly with HIV and CMV, but immunosuppressing states. And the outcomes can be poor if we're not suspecting CMV and getting treatment on board in a timely manner. Next slide, please. So what do I do in my practice, and what does our team do in our practice? So essentially, if we have an immunocompetent individual who's presenting with a viral encephalitis, we will test for HSV, enterovirus and parechovirus as a first-line screen. If that returns negative, then we'll review the patient and see if we need to extend any screening out. If we are presented with an immunocompromised patient, as a first-line screen, we will include the HSV, enterovirus and parechovirus, but we also include the following pathogens, certainly of CMV, EBV, adenovirus, HHV 6 and 7, particularly if we're in a hematology-oncology setting, and JC virus, if that's clinically fitting. JC virus does present slightly different to your typical viral encephalitis. And we may also need to consider, particularly if we're testing some of these other more ubiquitous herpes viruses, a paired blood viral load, particularly if the CSF is bloody. So if we've got red blood cells in our CSF, consider doing a viral load as well, because it may be that there is a traumatic tap going on, and what you're detecting in the CSF is actually from the peripheral circulation. That doesn't mean you don't treat it, though. So in terms of management of CMV CNS infection, as patients present empirically, they are started on IV acyclovir. If I had a patient that was then detected with CMV in their CNS, I would be advising that that treatment then gets changed to IV ganciclovir. And we would repeat the LP after 2 weeks to see if the pathogen is still present or not. And I would also be considering monitoring viral loads throughout that presentation as well, to make sure that that viral load was decreasing in line with the treatment. Next slide, please. And so that concludes what I was going to discuss today around CMV in 2 patient settings. If there's any questions, I'd like to open it up to the floor now.
Hi, Lisa. Can you hear me okay?
I can, yes.
Great. Just a quick question. I just saw something about the National Screening Committee in the UK opening up a consultation on CMV screening. I just wanted to know what your thoughts were on this, based on the previous publications and evidence base, and whether or not you think it's going to infer practice in the future.
Personally, I think there is scope to now look at screening. I think the previous arguments that we had in terms of no interventions and not knowing who and when to screen, I think the evidence that's come through the last few years means that we absolutely certainly need to revisit it and be doing some cost benefit analysis on the screening. The guidelines from Europe suggest you should be screening in the first trimester and then following up those women that are CMV IgG negative. So those that are seronegative and therefore at risk of a primary CMV. Obviously, we need to be really careful because that doesn't then pick up those individuals who have already had CMV reactivate and then also have issues with their pregnancies. But by screening seronegative women and following them up, that would reduce the disease burden significantly because that's your highest risk population in terms of risk to the fetus and the intervention that's there. But we would need to have further thoughts about what happens for those women who have a reactivation and a significant infection during reactivation. I don't think there's significant information known, or sufficient information known, I should say, around the reactivation side of things.
That's great. Thank you so much. I think we're just waiting for any further questions, but just while we're waiting, as a follow-up, has anyone done any research on the health economic basis for screening and what that would look like?
Not that I've seen, to be honest, but I think that's definitely an area that would need certainly exploring, particularly as CMV has that link to socioeconomic backgrounds. So yeah, I'm not aware of any. And can I also say around the screening, that's my personal opinion as a virologist, and I know there's very controversial views out there around that matter. That's my personal.
No, that's absolutely fine. Thank you so much for sharing your thoughts.
Thank you, Lisa. So there are questions in the Q&A. So we have one from Lucy Harrell. What is the use of CMV avidity in serology testing?
So we would use that if we had basically essentially use it if we get, so if we test somebody who has a anomaly screen, for example, and we find something that could be consistent with CMV, we test their acute blood, we find out that they're IgG positive or even IgM positive, because IgM can hang around for a while. If we then go back to their booking blood, if their booking blood is completely negative, we don't really need to do that much with it because that's a documented seroconversion. Where avidity potentially, well, not potentially, where it comes into its own is when you've got somebody who has got an IgG in that booking blood sample with or without an IgM, and we can then do an avidity on that and see whether that CMV was recently acquired or later acquired.
Okay, wonderful. We have another question, and it is on the clinical management that you showed. It was a very busy slide, but since you know CT and also CSF samples to the lab are sent, how critical is time to diagnosis in cases of encephalitis? How critical is to get this?
So usually patients are started on acyclovir empirically, not always, to be honest. But if they're on acyclovir and then you find a pathogen that needs another drug, then obviously that time is important in terms of that time to diagnosis, because that would mean that you would be then changing drugs. The longer that takes, the longer that patient is on incorrect treatment.
So please, if you have any questions, put it in the question mark icon. That is our Q&A box. So there is another question for Leah, and please, Leah, I thank you so much. Join us. So, do you know through your activity at CMV Action if there is an increasing number of patients and parents coming into support, asking for support?
I think actually, I don't have the statistics with me, but we've seen actually a decrease in people seeking support, but we don't know if that is because the peer-to-peer support groups are taking off and they're really working. It's something we're looking at in terms of how we can address the issue and see what's causing it. But there's a lot of positivity around these peer-to-peer support groups, which I think is because you can feel so alone and isolated, and actually the individuals are so incredibly knowledgeable as well. I've learned a lot from peers that are going through things and dealing with things in different ways.
Yeah, that's wonderful.
Leah, just as a follow-up,
Yep.
given that you've noticed more peer-to-peer support groups over time, do you think overall public awareness to CMV infection is growing?
Not enough. This is my personal view. The peer-to-peer support groups is something that we launched last year, I think it was October time. So they're still relatively new. But no, my personal view is that, I'm actually pregnant again at the moment, and still, even in medical settings, it's so amazing how few people know or have any decent knowledge of CMV. It's scary. So no, I don't think it's increasing in the way in which it should.
That's great. Thank you so much, and congratulations.
Thank you.
Just as a follow-up, I know obviously we're here today for CMV, but if anyone else on the call has got any passionate projects that they're involved with, what things have you found most effective for CMV Action in terms of spreading awareness for CMV? Is there anything that you'd like to sort of tidbits to pass on?
My personal peeve is, as a pregnant person, you spend so much time in waiting rooms, and there are posters about all manner of things, whether it's HIV, alcohol, breastfeeding, whatever it might be. And I think, we need to be targeting people in those settings, albeit, pre-pregnancy would be better, but trying to get those groups is hard. So I think just kind of getting the information out there as early as possible. I'm keen to try and work with, for example, nurseries, and try and find groups where people are likely to be perhaps going on to have another baby. It's a really hard one.
That's great. Thank you so much.
Thank you, Leah. So we have another question from Anne Valley, and this is to you, Lisa. If we were to increasing screening in the first trimester, what would this look like?
Sorry, what was the last bit? I didn't.
So yes, if we were to increase the screening in the first trimester, what would this look like?
So what they recommend in the European guidance, and what the European approach is essentially you screen you do your booking blood, you screen for CMV, and then for those women that are CMV negative, you then follow them up sort of once a fortnight until you hit 16 weeks, and then you can stop after 16 weeks because that risk massively reduces after then. You don't need to carry on screening throughout the pregnancy. That's what the data suggests, and that's what the certainly the European guidelines are suggesting and advocating for.
Okay. Do you think that it will be adopted widely in the UK?
I think there's more of an appetite for it since the data has come out and we've actually got an intervention. The big strong argument previously for no screening of CMV in pregnancy was because there was nothing we could do about it. Now we know that if we give women acyclovir, high dose valacyclovir, sorry, not acyclovir, valacyclovir, during that first trimester, we almost reduce that risk down to negligible risk if we get in early enough. There's no data for the second and third trimester, but certainly in that first trimester period, treating the CMV is a very significant intervention.
Yes, absolutely. Thank you, Lisa. Yes, so while we wait, yes, I don't see other questions. And
One area we're also looking at is something I'm trying to work with our neonatologists around is around the screening testing and getting those babies that fail their newborn hearing test screened. I think that's a really it's a big gap in what we're doing at the moment. I'm trying to work with our audiologists to bring that in. I think they do it at Barts, and there's a few centres across the UK that do it, but we're trying to do that at our centre.
Yes, absolutely. Okay, so thank you so much, Lisa and Leah. So thank you also for all of the patient journey that you have brought us, Leah, and how it was your experience with Beth. And again, congratulations on this pregnancy. It is, I think that the beacon of the presentation that there's still a move forward as well with the actions that you're doing with the charity. So thank you, Leah. Thank you so much, Dr. Lisa Berry, for sharing all of these clinical insights and perspective and updating us on all of these clinical nuggets. So I'm going to ask everyone of you attendees that if you are interested in your CPD certificate, please scan this QR code. I'm going to leave it here, and I'm going to put it in the chat box for you to fill in. And it seems that I cannot put the link, but hopefully it comes up with the QR code. So, oh yes, we have thank you to the organizers and also to you speakers for this webinar. And it's coming through the Q&A box. Wonderful. So thank you so much, everyone. I'm going to leave this for a while so you can complete it. But thank you for your time and for all of your questions. And all of these recordings will be available as well, and we will be sharing them shortly. Thank you again, Leah, and also thank you again, Lisa, so much for your wonderful presentations.